Thanks for having me today, and I'm very excited to talk about a topic that is a passion of mine. I did a full fellowship in this. I enjoy the opportunity to treat patients with epilepsy, and I'm honored to have joined the Billings Clinic and to become an epileptologist for people of the state of Montana. Today I'm going to talk about, boy, this is so loud to hear myself. Today I'm going to talk about a lifestyle-focused approach to living well with epilepsy. It's an under-recognized and not frequently addressed aspect of patient care in patients with epilepsy. So epilepsy, what is epilepsy? Epilepsy affects approximately 2.3 million Americans. It is the nation's fourth most common neurologic disorder after migraine, stroke, and Alzheimer's disease. Living with epilepsy is more than just a seizure prevention with medication, given that epilepsy is a complex spectrum of disorders. Treating patients with epilepsy should encompass a lifestyle-focused approach and with an emphasis on quality of life. So what causes epilepsy? There's no single cause of epilepsy. Anything that disrupts the pattern of electrical activity in the brain can lead to seizures. In many cases, the cause of epilepsy is unknown. Epilepsy can be due to an injury to the brain, such as oxygen deprivation. It can be due to stroke, traumatic brain injury, to name a few. And genetics can play a role, particularly in pediatric patients. So who gets epilepsy? 5 to 10% out of every 1,000 people will develop epilepsy. It is commonly diagnosed in children. However, after the age of 55, the rate of new cases of epilepsy starts to increase due to strokes, brain tumors, and Alzheimer's disease. This, as you know, is, I guess he's going back to Prince now, the artist formerly known as, or he is Prince. He actually has epilepsy. And he was very candid in an article with how he dealt with epilepsy as a child. And I really appreciate that he was one of the few famous people with epilepsy to kind of come forward and actually address it. So the epidemiology of epilepsy. It affects more than 65 million people worldwide. It affects 1% of the population by the age of 20 and 3% by the age of 75. 1 in 26 people will develop epilepsy in their lifetime. And epilepsy is more common in males than females, and 80% of those with epilepsy are in developing countries. How do you treat epilepsy? Most frequently, as physicians, we use medication. They're available to prevent seizures, and many patients can be seizure-free on medication alone. Other treatment options include surgery, vagal nerve stimulation, and the ketogenic diet, and I'll go more into the ketogenic diet later in the talk. So how can seizures be prevented? So there are triggers for epilepsy, and avoiding some of these triggers, such as the most common, which is missing anti-epileptic medication, illness, hypo or hyperglycemia, hormonal changes, metabolic disturbance, stress, physical or emotional, sleep deprivation, flashing lights for patients with photosensitive epilepsy, alcohol, drugs, and cigarette smoking. So the best preventative measure for patients with epilepsy is medication compliance. Seizures cannot be prevented by lifestyle changes alone. However, behavioral changes have the potential to improve patients' lives by giving them a sense of control in a disease process that has the potential to render patients virtually powerless. I will briefly address some of the lifestyle factors in epilepsy, and I will have resources at the end that can provide further reading and can be recommended to your patients. The ketogenic diet was initially introduced as a treatment for epilepsy in the 1920s. The diet is high in fat and low in carbohydrates and low in protein. He doesn't ever get the carrot. It's the carrot on the stick, kind of. At the time, pharmacological treatments were limited at best, and evidence supporting the diet as effective therapy began to emerge, particularly used at Johns Hopkins University. Fasting had been used to treat epilepsy since ancient times, and it was thought that this was effective due to ketosis. However, the mechanism of action is still not known. The ketogenic diet fell out of favor in the 1930s with the emergence of pharmacological treatments for epilepsy. The diet reemerged in the 1990s as a result of public campaigns, including the film First Do No Harm, which heralded the ketogenic diet as a quote-unquote miracle cure for epilepsy after the director's son Charlie who had medically refractory epilepsy benefited from this diet. The Charlie Foundation continues to work actively to promote education about the benefits of the ketogenic diet in the treatment of epilepsy. Adherence to the ketogenic diet is problematic, and it requires strict discipline on the part of the patient and the family, as well as guidance by a medical provider with specialty in nutrition. They have been looking into the modified Atkins diet and the low glycemic index diet, potentially as being as efficacious as the ketogenic diet and improved adherence because it's not as strict. That is ongoing evidence, but the results so far are fairly exciting. So osteoprotective factors in epilepsy. So the use of bone loss can occur in as little as 2 years of anti-epileptic drug exposure. And this is in both newer and older anti-epileptic drugs. Preventative counseling should begin in adolescence, given that up to 95% of bone development is completed by the age of 18. This should include addressing risk factors also, such as smoking, alcohol consumption, and sedentary lifestyle. Those can have an effect on bone remodeling. Supplementation with calcium and vitamin D has been shown to increase bone mass by as much as 11%, decreasing the risks of debilitating fractures significantly, which is important when your patients have seizures where they can collapse on the ground. For persons with childhood exposure to anti-epileptic drugs, adults with longer than 5 years of anti-epileptic drug use, and postmenopausal women, a DEXA scan should be ordered. Also encourage patients to exercise. Explaining the benefits of exercise can reinforce compliance. Weight-bearing exercise results in beneficial bone remodeling, among other benefits for patients with epilepsy. So exercise, it's an often neglected area of epilepsy. In many other chronic neurologic disorders, exercise is considered a disease-modulating factor. However, epilepsy patients are rarely prescribed or recommended an exercise regimen. Both clinical and experimental studies indicate that aerobic physical exercise programs may decrease seizure frequency. The mechanism of action is an ongoing area of active research. Patients with epilepsy should be encouraged to be as active as possible. A sedentary lifestyle is common in patients with epilepsy, as it is with the general population. Exercise is generally safe, inexpensive, and associated with benefits such as preventing weight gain and improving bone density, as previously mentioned. Also noting that patients with epilepsy suffer from comorbid depression, exercise has benefits for mental state and functioning as well. So let's talk a little bit about epilepsy and depression. Psychiatric comorbidities are prevalent in patients with epilepsy. It is important to note that any patient who suffers from any chronic medical condition can be at risk for depression. Up to 60% of patients with epilepsy suffer from depression and other psychiatric disorders. There is a bi-directional relationship in patients with epilepsy who are at risk for depression, and patients with depression are at risk for epilepsy. I haven't copyrighted this word yet, deprelepsy, but I'm looking to patent this word, but if anyone gets to it before me, it's okay. But basically, it is a bi-directional relationship. And interestingly, patients with depression and psychosis requiring inpatient therapy are at increased risk for developing seizures. Theories about the common underlying mechanisms for psychiatric disorders and epilepsy are an active area of ongoing research. Given that anti-epileptic drugs come with an FDA warning concerning suicidality, persons with epilepsy should be screened for depression. This photo here is a singer of a band in the 80s. His name is Ian Curtis, and he was a lead singer of a band called Joy Division. He famously had epilepsy to the point where what's the worst thing you could do? Be in bright flashing lights, and at shows he was, and he would have seizures on stage, frequently people thinking that it was part of his performance. He ended up committing suicide at the age of 23. So, screening tools for depression. Screening patients for depression in a busy clinical practice is problematic. This is the Neurological Disorders Depression Inventory for Epilepsy scale, aka the NDDI-E. It has been recognized as a rapid and effective method by which to evaluate patients for depression. It can be accessed through the Epilepsy Foundation website. The NDDI-E screen is brief, simple, easy to administer, and costs nothing. The scoring scale ranges from 6 to 24, with a score greater than 15 indicating signs or symptoms consistent with major depression. Ultimately, the value of the tool, however, depends on not only on its accuracy, but its ease of use, and also the availability and effective treatments and a clear management plan. One successful modality in addressing depression in epilepsy is the PEARLS program. PEARLS is a multidisciplinary approach to home-based treatment and for depression and intervention. It is a program initially designated for seniors that has been adapted to patients with epilepsy. Much like senior citizens, patients with epilepsy may be homebound due to driving restrictions and limited public transportation. Opportunities to obtain care for depression may be limited. At this time, availability of this program is limited to certain areas. However, at their website, there are helpful and interactive modules available, and I have listed the website here, www.pearlsprogram.org. Randomized controlled trials have demonstrated that 12 months out, people who participated in the PEARLS program had significantly lower depression scores and lower suicidal ideation than did people who were not participating in the PEARLS program, which I think is substantial. So this does have promise for patients with epilepsy. I just like this. I had to put it in there. Oops, I'm going the wrong way. Okay, so complementary and alternative medicine. Non-pharmacological therapies in complementary and alternative medicine are frequently used by patients with epilepsy, often without disclosure to their physicians. Patients often opt for alternative therapies for a multitude of reasons, mainly because frequently they're dissatisfied with the anti-epileptic drugs, their side effects, or frustrated with their lack of seizure control. Some examples of complementary and alternative medicine include nutraceuticals such as herbs and vitamins, mind-body medicine such as meditation and yoga, manipulative and body-based practices such as acupuncture, rolfing, and chiropractic manipulation, whole medical systems such as Ayurvedic medicine, homeopathy, and traditional Chinese medicine. There is a paucity of evidence to support the use of complementary and alternative medicine as an effective treatment for epilepsy. Although some randomized clinical control trials have demonstrated interesting results with the use of yoga, however, those studies are quite small. So even less evidence for the use of marijuana for the treatment of seizures. However, in one study, up to 24% of patients with epilepsy thought that marijuana was an effective treatment for epilepsy and actively use it. Approximately 52% of patients with epilepsy routinely take some form of supplementation or alternative therapy based on a survey conducted by the Barrow Neurologic Institute. It's always important to ask patients about complementary and alternative medicine, particularly supplementation, given that the risk of drug interactions with the current medications they're taking. Also, it's important to ask the patient why they're taking a particular supplement. Important for patients to be aware that nutraceutical industry is not regulated in any way or standardized, and they could be taking a capsule full of fillers or worse. Education is key, and alternative therapies are not an alternative to therapy. So this is probably for me, as an epileptologist, the most important thing because it causes breakthrough seizures, avoiding epileptic triggers. So it's the key aspect in addressing lifestyle factors, encouraging good sleep hygiene in your patients. The sleep-wake cycle is associated with prominent changes in the brain electrical activity and hormonal activity. So seizures in the sleep-wake cycle are often related. So sleep deprivation can lower seizure threshold. Diet, so hyperglycemia can trigger seizures. So I try to encourage good dietary habits to avoid peaks and troughs in blood sugar levels, particularly in my patients with diabetes. Avoiding excessive alcohol consumption. I would like to emphasize, though, that light to moderate alcohol use does not confer an increased risk over abstainers. The risk of seizure is higher in cigarette smokers, so I always try to encourage my patients to be smoking cessation. And it is not related to the amount of cigarettes smoked daily. So, my patient tells me they're cutting back. It's not as beneficial as completely stopping smoking. And then, this is obvious, but illicit drug use, such as cocaine and methamphetamine, should be avoided for a multitude of reasons. Flashing lights for patients who have photosensitive epilepsy. And then stress. Stress is a negative modulator of epilepsy. Patients commonly report stress as a seizure precipitant, although interestingly, when you review the literature, stress is very rarely mentioned or addressed as something that could cause seizures, but it's something that almost all of my patients say lowers their seizure threshold. Stress, interestingly, can cause forgetfulness, and so it can cause patients to miss their medications. And again, that goes back to medication non-compliance as being one of the most common causes of status epilepticus in patients with known epilepsy. So self-management. Epilepsy is a chronic disease and non-adherence to medication is rife. Up to 60% of patients are not adequately adhering to their medication regimen. Self-management for patients with epilepsy refers to adaptive health behaviors that promote seizure control, ultimately enhancing their overall well-being. Chronic diseases such as heart disease, lung disease, and diabetes have well-established chronic disease self-management programs. The primary tasks taught in self-management programs are medication management, particularly adherence, role management, such as responsibilities and recreational activities, emotional management, again, addressing depression, coping mechanisms, especially with stress. And given that behavioral issues are amenable to self-management, studies are currently ongoing for intervention efforts as a way to develop self-efficacy and self-determination. So unfortunately, you can't see this very well, but it is www.webease.org. They have a great PowerPoint here, the Epilepsy Self-Management Programs 101. This is an excellent resource, and I highly recommend exploring this website. They have other additional information, other links that you can go to. It's very, very helpful. And then, of course, the Epilepsy Foundation is a great resource as well. Here are some other resources. There's the Epilepsy Association of Montana. When I went to the website, they do have some excellent resources there, and hopefully I could become a part of that and help build on that. The Epilepsy Foundation is one of my favorite resources to go to. The Managing Epilepsy Well Network, American Epilepsy Society, we have an annual meeting every year. I'm an active member and will be attending that in December. Then the CDC has a good website, Epilepsy Advocate, and then the Billings Clinic actually has, in the neurosciences department, we have some links to information and resources there as well. So as a neurologist, one of the most important aspects for patients in living well with epilepsy is establishing a strong and trusting relationship. Our responsibility as physicians is to ensure that we provide the highest quality of care to our patients with epilepsy. The American Academy of Neurology has developed standardized quality measures for the care of several neurologic conditions, including stroke, Parkinson's disease, and then they released one in 2011 for epilepsy. And the goal was to address the quality of care with the idea that a minimum of and you can't see that very well either, the 8 following measures should be addressed at each visit by all providers who care for patients with epilepsy, not just epileptologists, particularly if you're addressing epilepsy at that visit. So number 1 would be seizure type and frequency. Number 2 would be documentation of the etiology of seizures if it's known. Number 3, the EEG results reviewed or ordered if appropriate. Number 4, imaging reviewed or ordered. Number 5, counseling about the anti-epileptic drug therapy they're on and the side effects. The other one would be number 6, surgical therapy discussed, counseled for referral if appropriate. Number 7, safety issues, which is imperative, including driving, bathing, swimming, cooking, and lifestyle changes. One thing I will address here is in Montana, the state driving law is that it is the physician's discretion. There is no established limit on how long a person should go without driving in the state of Montana. I always address driving at every visit. And then women-specific issues, including pregnancy and efficacy of oral contraceptive pills for women of childbearing age, and then, of course, osteoporosis risk factors in postmenopausal women. So widespread adoption of these performance measures for epilepsy care has the potential to substantially improve the quality of care for patients with epilepsy at all levels of healthcare delivery. Therefore, providing patients with the ultimate tools that they need to live well with epilepsy.